Alrighty, so this is going to be the second part of the recordings for the mental health exam too. This part of the recording is going to go over substance abuse and abuse disorders, okay, and the medications involved. Sorry, I'm just pulling up the document right now. So we're all not wondering what I'm doing. There we go. Alrighty, so this is going to go over care of substance use disorders. So I'm actually going to go back up real quick so we can define what a substance use disorder is, because that might be important going forward. So, a drug and drug-related disorder is substances with intoxication and withdrawal symptoms. So substance use disorders are complex diseases of the brain characterized by craving, seeking, and use regardless of the consequences. For example, somebody who's addicted to cocaine may have a craving to have more cocaine. Because of that, they're going to have substance use disorders and complications related to cocaine use. Because since they can't stop using it, their body's going to crave and crave more. And because of that, they're going to have consequences that occur. So it's pathological use of a substance that leads to disorder of usage based on impaired control, social impairment, risk of use, and physical effect. And as nurses, we're going to be dealing with a lot of patients who come into the hospital because of drug-related complications. Maybe they have really awful intoxication. Maybe they're in a withdrawal state. Maybe they come to just get some help. We're going to be the ones that are going to be helping them through this disorder and through their chronic problems. So it's very important to realize that an addiction is a compulsive or chronic requirement, that there's a need so strong to generate distress if left unfilled, meaning a person wants so much of a substance that they can't stop using it. Intoxication is when there's a disturbance in cognition or behavior, LSD, judgment, other functions based on the effect of the substance. And because of that, the substance can cause serious mental and physical state problems. Withdrawal is those physiological and mental readjustments because of a discontinuation of addictive substance. So intoxication is going to be a lot of your effect of the substance. Withdrawal is when you stop using it. So a lot of your withdrawal symptoms are going to be those rebound effects from intoxication. Suppose you drink a lot of alcohol. You have an alcohol disorder. You're addicted to alcohol because you can't stop using it. Because of you using alcohol, you need it to be able to function. And when you drink too much alcohol, it can disturb your cognition, and that's your intoxication. However, if you stop alcohol, you're going to feel those rebound effects. And then tolerance is an increased need to have a drug or substance to produce the drug's intended effect. Meaning that once you drink one bottle of alcohol, you're going to drink maybe 2 or 3 more. Because once your body can handle having enough of one substance, it's going to keep wanting to grow more and more to get that pleasurable effect. Okay, now we're going to go down a little bit. Okay, so one thing we need to know about when we talk about substance use disorders is commonly abused drugs, because we need to know what the heck the person's using. And there's Schedule 1 to Schedule 4 drugs, and a lot of these Schedule 1 drugs are going to be illegal in these states. And usually if we have a patient that's on these, they're going to be charged. like your heroin users, your cannabis users. Schedule 1 and Schedule 2 have high potentials to be abused, and a lot of these medications might be familiar, maybe cocaine, methamphetamine, oxycodone, hydromorphone, fentanyl, Adderall, methylphenidate. A lot of these medications, remember, we use methylphenidate to help us focus. Hydromorphone and oxy, fentanyl for pain, Adderall, cocaine. All these Schedule Q drugs we can use for certain disorders. However, once they start being abused, that can be a problem. So a lot of these Schedule 2 drugs you have to get from either a site like methadone. You can get them from a site. You have to get them from a site that's protected because they can be abused, and we want to make sure that our patient doesn't abuse them. Usually you can only get them with a script. You can't get them online. You have to get them from the pharmacy. It has to be you who gets them. You can only have a certain amount that you get. Schedule 3 drugs, moderate to low potential. Schedule 4 drugs, you can be abused. Schedule 5. You can look this up on the CDC website or the FDA, but remember, with a lot of our patients, we might be seeing this on their UAs or their CBC screenings, and we need to be aware of that when it comes to their disorders, because they might be abusing these substances. Some more abusive substances, we got alcohol, caffeine. Caffeine can be an abusive substance, surprisingly. I don't know if you all have a coffee addiction, but I sure do. Hallucinogens, inhalants, opioids, highly alcohol, opioids, stimulants, sedatives, smoking, nicotine. Of course, there's all risk factors. Remember, genetics is a big thing with alcohol disorders because children of alcoholics are more likely to have an alcoholic disorder or develop binge drinking habits. Biochemistry, remember, changes in the brain can occur with addiction, and because of substance activation, pleasure and reward can occur, as well as those memories that trigger desire to repeat, and because of that, a substance disorder occurs. Developmental influences that's based in childhood and unconscious anxiety, personality factors, low self-esteem, passivity. You mean those patients that are hopeless and the only thing they turn to is alcohol. Maybe it's a substance. Maybe they turn towards heroin use or cocaine use or Xanax use. I don't know. I don't do drugs, so hopefully I never have to deal with any of this. But it's sad that a lot of our patients, that we need to know about what might be causing behind this and what might the patient have in their lifestyle that may be contributing to a disorder occurring. Okay. Social learning. Remember, a lot of substance abuse disorders can come on because one is modeling after their friends. For instance, they hang out with their friends and their friend asks they're doing marijuana in the back of the school or something like that. And you go with them and you see them doing it and then you want to do it too, or else you're going to look like chicken. Peer pressure is a big thing too. Because of that, substance disorders will occur. Conditioning, learned responses. Remember, if you do it in a certain environment and there's a pleasurable experience, you might do it in the same environment. Cultures and the cognitive. Remember, irrational thinking patterns can cause a problem with addiction. A lot of times with your addiction disorders, it's going to be that those defense mechanisms of denial and compensation and rationalization. Denial. They're going to deny they have a problem. They're going to compensate by doing something good but not realizing that they have the disorder. They might rationalize other things to show them that their disorder isn't that important when it really is. So one thing as a nurse we need to know is, how are these patients going to look when we see them in withdrawal and intoxication, when we're doing our assessment of that patient? You can see stuff from their UA, from their tox screening, but we need to know if that patient's in intoxication or if they're withdrawing, and that's going to determine what kind of treatment we're going to need to give them. So cannabis, intoxication, impaired motor concentration, euphoria, slowed judgment, impaired judgment, withdrawal. Withdrawal is going to be a lot of that anger, aggression, irritability, anxiety, decreased appetite, restlessness, lowered mood, tremors, sweating, fever. Think about a lot of these withdrawal stuff is going to be that like rebound. Intoxication might be that sedation, that slowed movement, that pleasurable experience. Well, withdrawal is going to be a lot of that sickening stuff. Then insomnia, that aggression. Opioids, remember, desensitize that pain senses and gets pleasure. They're going to have drowsiness, slurred speech, impaired memory, slowness, small pupils, intense drowsiness because they're in pleasurable states right now. Well, in withdrawal, they're going to have fast, they're going to have spasms, they're going to have anxiety, cramps, vomiting, diarrhea, aggressiveness, dilation of those pupils because they're in that state of panic. And then remember, with a lot of these substances, overdose may occur. And when somebody ODs on something, death can occur because of respiratory arrest, cardiac arrest, seizures, strokes, liver intoxication. Remember, with any overdose, you want to make sure you know your ABCs. Remember, you need to make sure that they have an airway, they don't aspirate anything, they can breathe, and that they have a pulse. One thing is that you can use naloxone for that opioid kind of like antidote. However, you're going to use naltrexone for that prevention. So naltrexone and naloxone sound very similar, but naloxone is going to be used as an antidote for opioid toxicity, which comes with your overdose because you have too much opioid medication in your damn body. So naloxone is going to help reverse that. However, to control that withdrawal, it's going to be that naltrexone. Remember, with naltrexone, you're kind of like running away from being in that withdrawal. Well, with naloxone, it's that antidote. So that's kind of a little method to help you remember it. Naltrexone, you're trekking away from having withdrawal. Sedative, hypnotics, cause of CNS depression, slurred speech, with intoxication, impaired thinking, unsteady gait. All of your substances are going to have nystagmus, which a lot of, remember your field sobriety tests where the police officer has to put your finger and you have to follow the finger, and to see if there's smooth pursuit. Well, nystagmus is when there's not a smooth pursuit of the eyes and they all jump around. And that's going to be common for a lot of your intoxications with all of your substances. So that's going to be a key feature. Overdose is common. Remember, a lot of your overdose treatments, you can use that gastric lavage, or if there's an antidote. Remember, we want to prevent LOC loss, withdrawal. A lot of your withdrawals you can use with your benzos. Benzodiazepines is going to be key for that. And we're going to talk about benzos with alcohol abuse. Am I recording? Okay. Stimulant use disorders. Remember, stimulants, amphetamines, they amp you up. However, people do abuse these and can become toxic. Remember that these people, they feel superhuman, elated, euphoric because amphetamines are stimulants and they make you, they amp you up. Withdrawal, remember agitation, anxious, cravings, depression, lethargic, crashing. It's going to be kind of the opposite with your stimulants. Remember, detox can help make the process tolerable. Remember, we're going to go over detox meds. Alcohol use disorders. Alcohol is very common and many times used for recreational purposes. However, if it gets out of control, it can be very costly to somebody's health. Alcoholic phases, remember pre-alcoholic phase, relieves everyday tensions, The child may observe their parents drinking it. Tolerance can develop in the patient. And then early alcoholic is when you keep having blackouts, a lot of drinking, sneaking drinks, drinking of drinks too fast, lots of denial and rationalization use. Again, we saw that earlier. Crucial phase is when they lose control of the addiction. They can't choose whether or not to drink. They binge drink. Remember, a key factor that we can measure in patients to see if they're abusing alcohol is their BAC level. If it's higher than 8, that means they're intoxicated, and that can be very troublesome. And if it's like above 30, they can be in like a coma, or if like it's above 4, a 0.4, they're gonna be like dead. So it's very important to measure this. Anger and aggression can occur in the crucial phase. Chronic phase is when they have, when they can start losing their relationships here. Because a lot of time that alcohol disorder, yeah, it might affect them, but it's going to affect their loved ones if they know it's happening. So chronic phase is when they have emotional disintegration. They're helpless, self-pity. Often in the 3rd and 4th stages, they're going to enroll in those 12-step meetings to help with recuperation and recovery, if they're willing to change. Okay, and now we need to know about, because suicidal ideation can occur with the drinks, along with those psychosis. And if they stop drinking, it can be fatal, because remember that rebound effect. Mild to moderate alcohol intoxication, lack of appetite, insomnia, agitation, perception changes, high blood pressure, high pulse. Think about how you feel like when you have 2 drinks with your boyfriend out on a Saturday night. These people feel like this constantly. Complications can occur. Alcohol cardiomyopathy is when the heart muscle becomes enlarged and the heart can't pump blood effectively. Alcoholic myopathy deals with the muscles and contraction. Fetal alcohol syndrome is a big concern for pregnant women, because if a pregnant woman drinks too much alcohol, their fetus can be damaged, or they can have severe defects in the child. That's why we should not be using alcohol in pregnancy. And we'll learn more about this in maternal child health. But fetal alcohol syndrome can potentially cause the fetus to die. Severe alcohol withdrawal delirium is an emergency situation where there's autonomic hyperactivity of the body. Remember, tachycardia, sweating, insomnia, hypertension, delusions, hallucination. We're going to use benzodiazepine, and then benzodiazepine to reduce the agitation, and chloride epoxide. Our antidote, remember, with any benzodiazepine is flumazenil. So, if they ask you what the antidote is for somebody going through alcohol toxicity, and they're using benzodiazepines, or benzodiazepine toxicity, we're going to use that, flumazenil. Okay. Lab testing is going to be key here, because we need to know what the hell the person has inside of them. We want to know what they're positive for in their UA. We can get a CBC, blood alcohol culture. Urinalysis is going to be very, very common. Sputum cultures, saliva tests, FNE evaluation, because alcohol withdrawal in a lot of these disorders can cause enzymes to not be there. They can cause vitamin deficiency, thiamine deficiency, diet deficiency. It can cause them to lose fluids very quickly, cause them to be dehydrated. I don't know about you, but every time I have an alcoholic beverage or a glass of wine, I want to drink a crap ton of water afterwards. But you can lose fluids, so we want to make sure we check for that as well and correct that imbalance. Here's some more nursing interventions. Remember, we always want to do a complete assessment of our patient who has a substance abuse disorder. Remember, we want to make sure we get a urine sample, blood sample, saliva sample, get a history on what the drug is, and we're going to go into those questionnaires. low stimuli, quiet environment. Make sure if you need to have a one-on-one basis or closed obs, you can do that. Assist the patient when ambulating, because a lot of times the patient in withdrawal may not be able to stand up, or if they're intoxicated, they may not be able to stand up. Seizure precautions are going to be needed. Suicide precautions, if they need it as well. Remember, no smoking materials, especially if they're in the hospital, because oxygen is a thing, and oxygen and smoking do not go well together. Always orientate the patient to reality. Monitor vitals and symptoms. Help with denial. Remember, ensure that it's not you, but the behavior. Think about that. Remember, identify maladaptive behaviors. Remember, the first step is to distinguish that relationship. Don't really use confrontation, because that's not right. In effective coping, we want to know set limits, structure, explain effects, explore options, give reinforcement for gratification. A lot of stuff is with the family as well, so make sure that we talk with the family about family history, their roles, extent of the behaviors that they've seen, what maybe they've done to their loved ones. Involve them in their care, because the family's going to be the one that's going to be taking care of this client when they get home. Allow the partners to understand abstinence and involve them in discharge planning. Refer them and the family to AA or 12-step meetings, because a lot of times you're going to need that sponsor to help with that therapy. Another big thing is that assessment. We need to know about substance use, history of substance use, genetics, family substance use, what kind of substance, how long, how often, how much, last incidents, any arrests, injuries, stopping, do they have a support system willing to change? You can use CAGE, MAST, and then CWA. You're going to see that CWA a lot. And then codependence is when they have learned behaviors in relief that make painful because of that substance use disorder, and they just depend on other people to do things. And they depend on other things to do things because of that. Counseling is a thing too. Group therapy. A lot of that group therapy can be used with your AA meetings. That's an example of group therapy. Those patients benefit from each other and learning on the teachings of Al-Anon and build something. But it's a group that's coming together to help with each other about the alcohol use or their substance use. Because there's also ones for substances like Narcotics Anonymous, Gamblers Anonymous. There's a lot of that. So now we go into medications. And I don't know who did this to my doc, but it's going to be very hard to read, but I'm going to try my best. So if we're having a patient that has alcohol withdrawal, the first thing we're going to use is a benzo. Because a benzo is going to help with that decreasing of intensity of withdrawal symptoms. Remember, it can cause CNS depression, anhydrous sleep driving, depression, and abuse. Always remember, monitor for toxicity, and give flumazenil as needed. Get vitals, assess neuros, take as prescribed, taper the med, give at bedtime or with meals, small tablet whole. But if you have a patient that's in withdrawal, the first thing you're going to do is use a benzo. Once that patient is not in withdrawal anymore, we're going to use disulfiram to help with that abstinence maintenance. So disulfiram is an oral medication that is an aversion therapy, which can cause the patient to be sick if they use alcohol while using the med. So it can cause that acetohide syndrome, nausea, vomiting, basically very sickness. And it can progress to death if the patient keeps using that alcohol while using the medicine. It's very dangerous. Remember, we need to teach the client to not drink alcohol with this med, avoid any alcohol products like cough syrup, aftershave, mouthwash, hand sanitizer. Fun fact, a lot of our patients that have like an alcohol use disorder, they might try and drink the hand sanitizer from the there's a station. So if there's hand sanitizer in a patient's room that's going through alcohol withdrawal or alcohol maintenance, we might need to remove it or put it outside the room because the patient might try and drink it, and we're not going to do that. They need to wear a medical alert bracelet and participate in self-help, aka your 12-step program. Now Trexone. Remember, we're trekking away from alcohol and opioid dependence. It's going to suppress that craving and effects of alcohol and opioid withdrawal. Now Trexone, trekking away. It's a depot medication, so depot medications are going to help patients that have a harder time adhering to medication regimens. They go in for like every 3 weeks for like an IM injection, and then they leave. And it helps them. But we need to teach them that they need to make sure they come in and stay on top of everything and do not use alcohol or substance while getting those injections. Remember, we always want to do a thorough assessment. Acamprosate is another med. Helps with abstinence. Taken orally can cause diarrhea. Remember, no pregnancy use. Take with meals. Methadone. So methadone is also very common. It's going to be that substitution detox therapy for opioid use and opioid dependence. So it's going to prevent that abstinence syndrome. And removes the need for obtaining illegal opioids. However, one thing that we need to know about methadone is that it can't be getting like over the counter at a pharmacy. You have to go to a methadone deposition center for you to get the medication, because it can be very dangerous. Remember, it needs to be always tapered, administered from an approved treatment center. Remember that we need to make sure that the client goes to the 12-step program, of course, while they're on this med too. Clonidine helps with autonomic hyperactivity. Buprenorphine helps with cravings, for opioid cravings. Bupropion helps nicotine cravings. However, remember the difference between buprenorphine and bupropion. Buprenorphine kind of sounds like morphine, and morphine's an opioid, while bupropion is that proper people smoke cigarettes. I don't know why, but it's a thing. But bupropion helps with your nicotine withdrawal. So a lot of people who are going through nicotine withdrawal, they'll use these medications like nicotine patches, sprays to help with that tobacco cessation. It's very common. You'll see a lot of people ask for their nicotine patches at the hospital because they can't smoke. They might ask for a lozenge. They might ask for a spray, gum, but the nurse will get that. So we have to get that for them. But remember, with nicotine gum, there's certain precautions that we have to do. Remember the patches. Remember, rotate your sites. Remember, you can only have it on 16 hours of the day. Remember, cleanse the site after you use it. Put it on with gloves. Remember, rotate sites. Remember, avoid inhalers with those who have asthma. Taper that inhaler. No breastfeeding, no pregnancy with these. Remove patches for MRI. Lozenges. Remember that you can only have 5 in a 6-hour period. So if the patient has had 8 in a 6-hour period, that's a problem. And then there's varicycline. Nicotinic receptor reduces cravings of nicotine. Okay. Varicycline, I guess that you can't use drugs. Now, I want to spend a few minutes on AA meetings. So, I don't know if any of you have been to an AA meeting, but at my old program, before I came to Rasmussen, we were required to go sit in on an AA meeting to just kind of see what goes on in the meeting and what happens. So, Alcoholics Anonymous is a self-help organization for those with alcoholism or substance use disorders, and they're based on the concept of peer support and acceptance for understanding them from others with like the same problem, this is the kind of type of group therapy or support groups. Remember, membership is based on the alcoholic person to stop drinking. They're all going to get a support sponsor to help with that assistance when drinking occurs. For example, maybe my partner, her name is Lindsay. Lindsay sees me trying to sneak a beer in to go watch the Super Bowl. If I'm in an AA meeting, if I'm an AA person, Lindsay's going to tell me, nope, you can't have that drink. You vowed to not drink. So, because of that, I'm going to give you a Gatorade, and we need to talk about this. Because remember that Alcoholics Anonymous accepts this as an illness, and the promotion is total abstinence as a cure, and that the person can never safely return to drinking. Remember, sobriety is very important with these patients. And because of that, we have those 12 steps. Powerless, they have to succumb to that greater power. A lot of times at these meetings, they'll do general prayers. Admit to God. God removes the defects, shortcomings, spiritual awakenings. But under these circumstances, they're able to realize, hey, I need to be sober. People depend on me to be sober. And they're going to stop drinking because of this. People have been very successful with this. There's people who've been lifelong non-alcoholics because of use of AA meetings. So these are very, very, very important for many patients. A lot of times we will refer our patients to go to AA meetings. Yeah. So, collaboration, we're going to want to definitely include the family with that. Make sure the provider knows. Monitoring for the disorder, counselor, psychologist, counseling, psychiatrist for those medications. They may need certain medications for the disorder. Dietitian, we need to make sure they get a good diet in. AA support person, phlebotomist for those blood draws. If a patient comes in and they're under a substance or deemed by a substance, we may place them on an involuntary hold called a Marchment Act to ensure that they don't abuse substances anymore. And then after that, they'll go to a detox clinic to help with that withdrawal. So safety is also a primary focus here with acute intoxication or withdrawal, because patients can have some very, very costly effects. Remember, safe environment to prevent falls. Maybe these patients may have a hard time moving because of the intoxication or withdrawal symptoms. Seizure precautions can occur from withdrawal or intoxication. They need that observation, complete supervision for those withdrawal manifestations and aggression. Don't put physical restraints on this patient unless you have to. Remember, you should always use the restraint for if the patient's going to harm themselves or others. Not because you want to, not because they're aggressive. It's if they're physically going to harm themselves or other people. Remember, orientation is, of course, always make sure that they get fluids, low stimuli environment, because if they have that high stimuli environment, they may be very overwhelmed and aggressive. Do your substitution therapy. Monitor for substance use during detoxification. And if you do not control any of these, consequences can occur. Stroke, cardiac arrest, respiratory failure, injury, addiction, disrupted family issues, divorces, because if the patient is on a substance, abuse can occur within the family. The family can become disruptive. The patient's not going to be wanting, the family's not going to be wanting to be around the patient, and it can cause relationship issues. And that's why many children, they're taken away from their homes if their parent has a substance abuse issue. Divorces can occur, and that can ruin the child's childhood, and that's no fun. So we need to be aware of many complications, not just for like the body complications, but also in the outside circumstance, in their social life. Their friends may not want to be around them anymore because they do a substance. Okay? Any questions about that? Any questions?
No questions.
No questions? I hope I'm doing a good job recording this.